Every woman should have access to the pill to use it for whatever reason she wants. I feel incredibly conflicted about the pill.
It gave women the opportunity to make a choice, but there was so much stigma.
It was my husband holding the mirror up being like, you're a totally different person. And I was like, I feel different. Okay, valid. This does not work for me.
80% of the symptoms that women in perimenopause are struggling with are going to be brain-related, mood-related, cognitive-related.
Men are believed about their symptoms. Women are not. There is no right answer. There is informed consent and what the woman decides for herself. Even if you tell your story and you feel like no one's listening, you are shaping and changing women's health for the better. Women collectively want access to this, and we absolutely can retain access to this if we unite.
When you light up a room.
Hello, everyone, and welcome back to Luminescence. This is a show for women by women, and this season is all about sex, hormones, and intimacy. Because women's health has simply not gotten the attention it's deserved for thousands of years, and we are here to try and fix that. Today, we are diving headlong into one of the most revolutionary and controversial medical inventions for women, hormonal contraception. And I gotta tell you, I feel incredibly conflicted about the pill. When the FDA approved it in 1960, it was undeniably an absolute game changer for women's independence. And on the other hand, the side effects are wild and just not widely researched or known. So how do we navigate this balance? This is a real cost-benefit analysis that every woman needs to make for herself. But many of us don't even have the basic facts about the hidden costs of the pill. I am your host, Skylar Grant, and joining me today are three incredible women: menopause expert Dr. Marisa Snyder, holistic wellness coach and meditation teacher Rosie Acosta, and naturopathic endocrinologist and clinical sexologist Dr. Jolene Brighton. So, ladies, what the fuck is happening with the pill? How does it work with our natural pharmacy? Like, is it accurate that it fundamentally rewrites our sexual blueprint and more women are taking it to manage non-pregnancy issues like hormonal acne and endometriosis and PCOS? And there are still religious and political movements who look at the pill like it is the devil's candy. So, Rosie, maybe you can give us a little more background on the pill and like how it's so controversial.
Yeah, I mean, when it was approved in the 60s, it was revolutionizing, right? It gave women the opportunity to make a choice, to maybe focus on their career or focus more on how they wanted to create a family. But there was so much stigma even in that liberation movement because we didn't know how it was going to affect us long term. We didn't know the implications it was going to create within communities. And obviously you said the devil's candy, right? Like from a religious or perhaps cultural standpoint. So I think it's really important to look at all those factors of how we're being affected, not just physically, and I'm sure the doctors can speak to the physical implications of it, but also just the psychological effects of what we had to deal with. And even now, right? Because it's interesting. You said I'm torn, and I kind of wanted to ask you the question, like, why are you torn about how you feel about birth control?
I mean, I'm super torn because it's the easiest, absolutely most reliable form of birth control. I mean, that I know of. You know, Jolene's laughing at me, I mean, it's like
the propaganda goes strong.
But I mean, listen. I was on the pill for a year. I've used the cervical cap. I've used the diaphragm. I've used, the rhythm method a lot. Don't tell my children. And I got off the pill because I didn't like how it made me feel. But I will say it was more convenient. I mean, it was nice not to have to deal with a diaphragm or a cervical cap. And then I had an IUD. I finally had and I like the IUD, actually. I had a copper IUD. So I would say, but getting that IUD in was worse than childbirth.
Because the United States does not prioritize women's pain management, which is why it's one of the only developed nations in the entire world that has only in 2025 recognized and looked at the research to say that telling women to take ibuprofen is not sufficient. And whereas every other developed nation, and even those that we call developing nations, they call the way we practice women's medicine barbaric. In the lack of pain
It felt
management.
barbaric.
It was. I was the worst thing that ever I did to my uterus.
No, I was like, I'm fine. I've had 3 unmedicated births. No problem.
Yeah.
Put
No,
that
it was
little
awful.
guy in there. And I was just like, motherfucker.
How many of us have been on hormonal birth control of some variety at some
Yeah,
point?
I
all
did
of
10
us.
years.
Okay.
Yeah.
Oh, I didn't know that.
Yeah, I did a decade on the pill. And then when I went through IVF, I tried the pill again to try to space and time things. And became completely a mess and depressed. And even though I wrote the book Beyond the Pill, I was like, no, you can't be depressed that quickly. And it was my husband holding the mirror up being like, you're a totally different person. And I was like, I feel different. Okay, valid. This does not work for me. I do want to note that when you talk about efficacy rates, nothing rivals a vasectomy. Vasectomy is absolutely the gold standard of birth control, and it doesn't require a woman hijacking her own hormonal physiology. Second to that is the IUD.
Amen.
IUD has a very high efficacy rate. And then when we look at the
Even the copper IUD with no hormones.
Yes. Yeah, you don't need the hormones. It'll be just as effective. The hormones are there because that thins the uterine lining. That can help in some cases when women are having heavy bleeding. Like there's other ways that we're using it. And to your point, yes, roughly 60% of women report that they use the pill primarily for symptom management, not for actual pregnancy prevention. But to the efficacy rates, fertility awareness method, when done correctly, following the scientific outcomes of like what is the highest efficacy, which is cervical mucus, basal body temperature tracking, making sure you're checking your symptoms, and abstinence of penetrative sex, basically abstinence of exposure to sperm during that window. So for everyone listening who's like, oh, my friend got pregnant on the fertility awareness method, did they use the pull-out method? Because so many of my patients who've done that, I'm like, what'd you do during the fertile window? Well, we pulled out. Okay, that's the pull-out method that has a 20% failure rate. So we're talking about something different. But when you look at fertility awareness method next to the pill, typical use and perfect use, we find that fertility awareness method rivals the pill in terms of efficacy. However, fertility awareness method is not for everyone. It's not easy. It's not the rhythm method. It takes time to learn it, right? So someone's going to be like, I use FAM, it's easy because you learned it, but it's not as easy as just popping a daily pill, right? And so we have to, whenever we talk about birth control, whether it's hormonal or not, the best birth control is the one that works for you, has the least amount of side effects, and you can stick with that. And let me just say, a side effect of getting fertility awareness method wrong is having a baby. Are you okay with that? Or
having an abortion.
Or having an abortion.
Yeah.
Are you okay with that? And so there is no right answer. There is informed consent and what the woman decides for herself.
And what works for them as well. I did combination and Depo-Vera, and I made it a year before the symptoms were.
Is that the?
That's the shot.
Yeah.
Because again, informed consent or the lack thereof is the issue here. I know for me, I was told, oh, just do the Depo-Vera because you only have to come in quarterly. We'll give you the shot. I think 19 years old. And we're gonna get rid of your period. And oh my God, what a nightmare that experience was. And we know there's so many severe symptoms that can result from taking something like the Depo-Vera, including bone loss is one that women don't look at. So I remember.
Is that true with the pill generally, or is that just the
That's
Depo specifically?
Yeah.
Yeah. And so made it barely a year, took a year to get my cycle back. And then didn't do anything for a decade until I did the copper IUD. I remember on the third try, the doctor's like, I'm just not going to do it if we don't get it in this time, and it was just awful and excruciating. But the symptoms for me on that too were just so severe. Like I lasted 5 months.
Really? Your
that
symptoms
was
on the IUD?
on the copper.
Cramping.
And this is where I ask, who checked you for endometriosis or adenomyosis?
Yeah, nobody. No, and it was it was always mood related symptoms that were the worst for me, and the weight, which a doctor will argue with you that you don't gain weight on any of this.
Wait. You gained weight with the copper?
Even
IUD?
with the copper, yeah.
Explain this to me.
So it is still a disruption, not only the uterine lining, but also it's disrupting your cycle. It's disrupting hormones, and not in the sense that it's putting synthetic hormones in, but we're still disrupting biology. And so various, depending on the woman, even with a copper IUD, they can have symptoms. Some women do really well, some women don't. And I think to Jolene's point that, you got to find the method that works best for you. And so like using apps like Natural Cycles, or, I didn't get pregnant until 40 years old. I had my baby at 41 because we were using people, well, what do you use? I'm like, condoms.
Right.
And so there's other options that are available, especially if you were symptomatic on hormonal birth control or even like a copper IUD. So I wanted to just speak into that.
Do you recommend that the couples have a vasectomy and then just reverse it? Or is that just, would that be
that's a
bad?
good
Would that be
question.
bad medical practice?
That's a great question to have one-on-one with a men's health specialist about, because vasectomies can be reversed, but the skill of the person doing it absolutely matters. And so you want to have that conversation one-on-one. We are seeing more men starting to get vasectomies. They're 19. They're like, I want a vasectomy. And, you're told like within a 10-year window, sometimes it depends on who you talk to, of counseling of like, you're going to want to reverse that and you're going to want to try. Some men are doing protocols to get as healthy as possible, banking sperm, and then getting vasectomies as a backup.
Oh my God, totally
So
fascinating.
You're seeing men are interested in stepping into this conversation and taking some responsibility around this and starting to do their own family planning, which, the burden has always fallen on women to prevent pregnancy and to think of family planning. But now with the research coming out showing us that like the health of the baby, the health of the pregnancy, the risk of preeclampsia, this is all related to sperm health. Men starting to understand that. I think men are getting empowered now. And as much as, medicine has been like, men will never sign up for this, they never ask them. And when you ask men are like, yeah, I want the data. Yeah, I want the info. Yeah, I want to know what I can do too, because this is important, not just for my health, my partner's health, and my potential baby's health.
And has there ever been a medical push to research a pill for men?
Yeah, why do we have to always be the ones with the prevention? Why can't men take a birth control?
Let's talk about capitalism, okay? So this is what it comes down to. When the pill was introduced, this was the first time in history where you didn't have to have a diagnosable condition, you just had to have a set of ovaries. That's it. That, since we're talking about sex, I will say that's a marketer's wet dream. Like that is absolutely a gold mine for the pharmaceutical industry to get that pushed through the FDA. So we have to understand that piece. When they did do a trial, that was recently, I believe it was like 2016, 2018, somewhere in there. They did a trial on men. Men had the same exact side effects that women experience, mood effects, depression, to a lesser extent that women experience, and it was pulled off the market. At the same time, they released a new IUD, a progestin-based IUD, that had significantly more side effects for mental health than what you saw in this male trial, but they deemed it acceptable for women. And why? Because at the end of the day, and this sucks, and these men exist, they can walk away from a pregnancy. A woman cannot walk away from a pregnancy easily. And I know you brought up abortion, but that is not accessible for everyone. It's not within everyone's belief. Like, there is a lot of nuance. And even if you are someone who believes, like, yes, we should have a right to abortions, when it comes to you personally, there can be a big mental health toll on that. And we never talk about that enough. Even if you are like, I don't want to be a mother, I don't want this baby, there is grief. There are other things that can happen, but also there's the hormones that happen that you also have to process after the fact. And so really the pharmaceutical company said, like, if this has this many side effects, we can't keep investing money on it. There's no ROI here because we don't think the market will accept it. They won't purchase it. So this was a business decision, which is how we're set up.
Let me just ask, I mean, men are also 50% of the marketplace. Like if a viable pill for men was developed, that's another great product to be sold. Why wouldn't that product get developed as another option,
Because it's probably a hindrance for their routine.
No, but like, let me ask you, if I said to you, hey, I'm going to give you this medication to prevent pregnancy, but there's big possibility you might end up depressed, and then I'm gonna have to put you on an SSRI, and then that SSRI might tank your libido, and this medication's already tanking your libido. So the whole reason you started this was to have sex, and now you don't want to have sex. Like, if you had a
women
true,
go for it.
Yeah.
no, they
This is
don't,
true.
because they don't get a true informed consent. They don't
That's
go
true.
for it.
It is
they end
true.
up on it. They end up having side effects. They get told this is a you problem, not a
problem.
pill problem, and then they're like, well, what the hell's wrong with me? We know that dropouts are so high that when they do a birth control trial, they will test your binding proteins to make sure you're actually on it and you're not lying about it, because they know how often women do not like the side effects and drop out of these trials.
Okay, but I still want to push you on this. Because,
me, let's go.
So, but I still want to know, all of this, I completely agree with and makes sense. But I'm just asking from a corporate capitalist theory of the case, why not develop a pill for men and not tell them the side effects, just the way we're not telling women the side effects? I mean, why not have that other option in the marketplace to peddle on people? Because if men are being proactive enough, some of them, I'd imagine it's a fairly small percentage of men, to bank sperm and get a vasectomy, which is amazing.
Yeah,
That's
that's got to be a
proactive.
very small
Yeah.
percentage.
No, but here's the thing. Medical misogyny is real. It's
Yeah, I was
been
gonna
well
say, that's
documented.
what it is.
Men are believed about their symptoms.
Oh, that's
Women
true.
are not.
Well,
so
and
when
I
a
still
man goes
think-
to his doctor
yeah.
and says, I'm in pain, they're going to get pain medication. We sit in the emergency room waiting for pain medication about 20 minutes longer than a man having the same gastrointestinal symptoms. Okay? Same body parts. We're not believed about our pain. So that is the thing we have to understand, is that men would be believed about this. Also, men get treated differently. I mean, we even look at like the fact that endometriosis, a system-wide chronic condition affecting what we think is 1 in 7 women, not just a reproductive disease, gets $2 of funding per patient annually. Male pattern baldness gets more research. Something that is aesthetic gets more research than a debilitating chronic condition. We have always taxed women, taken their money to fund male research, and to make sure we're always developing the best treatments for them.
Yes.
Speak, Jolene.
Literally.
Well, and I would say that reproduction, the onus is on us. It's always been our responsibility. And so we need to be the ones in charge. It's our due diligence to control whether we get pregnant or not.
Yeah, but
or
it's also on us
manage.
to take all of the risk and suffer all of the
always. But
consequences.
It always has been that way.
We have to talk about that, though. We can't have this conversation without actually honoring the women of Puerto Rico who made birth control possible. Their bodies were non-consensually exploited with the promise that they'd stop forced sterilizing them, because if they participated in this trial, it might make them more fertile, lie, or they won't have to have these hysterectomies. They'll be able to have access to birth control. And they lied to them. These women died.
Was this in the 50s?
Yes.
Yes, 19,
Yes,
yeah.
Margaret Sanger. OG coercer of women,
Yeah.
like, does not deserve the accolades, like, for the birth control pill that she gets. So it is really the women
Let's get
of
into
this
it.
small island who got exploited, who gave up their lives, literally gave up their ability to become mothers so that all of us could have access to that today. And when the trial was all said and done, they priced that birth control pill out of their price range and continued to force sterilize them, to the point that no time in history have we ever seen a larger mass sterilization of women than those women of Puerto Rico who gave their lives so we could have the pill.
Yeah.
Wow.
And
that
they
is a
did,
bit of history I did not know.
they did the same thing for Indigenous women here in the U.S. They also did the same to women in Africa when they were studying for cures for
They also did it
AIDS
for
and HIV.
to slaves in like the early gynecological research was all
Absolutely.
done on Black women against
and
their
brown
will.
bodies
like
have always been
fistula
exploited.
surgery, like all of early gynecology. What's the godfather of gynecology? Sims. Yes. He gets
Another dirty name.
Another dirty bastard. I mean, they did come up with some amazing medical technologies, but at what
At what
cost?
risk?
Well, and we have to
risk of
say the
women.
elephant in the room is it has always been white women who have benefited from the exploitation of brown and Black women's bodies. And I want to be clear to every white woman who is listening right now, you didn't choose this. You didn't contribute to this. You did not make this happen. You do not have to feel guilty about this to hear these facts, but we do have to always question collectively as women as we move forward. Like, who is benefiting and who is being exploited in this. And so
who
we
continue and that pattern. And then, okay, so like,
and who lacks the access now?
who continues
Still
to be exploited and to not reap the benefit of these available technologies. Good, bad, or otherwise.
Absolutely. And that's such a clear point for everybody listening. We're not saying don't give women access to the pill because it has this dark history or it has these side effects. I am very much of the mindset that every woman should have access to the pill to use it for whatever reason she wants. She finds this works for her endometriosis, her heavy bleeding, her fibroids, and that's her choice. She wants to use it. Fantastic. This is how she wants to prevent pregnancy. Have at it. She deserves informed consent and access to all the options and to be supported in the choice she makes.
Okay,
and
so
that's
let's get
the center
let's
of this
get
conversation.
into, like, if you two doctors were women's dream go-to for their informed consent, like, what are give us the pros and cons, give us the side effects, like, drill into this.
I'm gonna start with mental health and then I'm gonna pass the ball to Marisa. So I think the very first thing that we have to understand is, while we have no studies that show causation, the pill causes depression. It's a very hard causation piece to even solve. And let's acknowledge that research was set up for the gold standard of male bodies and never thought about how to actually modify it for women's bodies. So we've got a research flaw. So with that in mind, if you tell me, though, I took the pill, I got depressed, I believe you. We know.
We don't understand that. We don't really understand that pathway, though.
Well, even mood swings or anxiety. Like, it's not just depression. You know, women just feeling just not like themselves.
Mood, it's a whole mood disorder.
It's a whole mood disorder. Yeah.
In my book, I have a whole chapter on this. I have several hypotheses. We know mechanisms of action and potential things happening, and toxic neurotransmitters being made, disruption of serotonin pathway, inflammation. Like, there's a lot. Okay, so but let me say this. Okay, so we know the critical window within the first 6 months of initiating pill use, you're most likely to start experiencing adverse mood symptoms. It can come on later. The people most at risk are going to be those who haven't had fully formed brains, so before the age of 25 years old. When we start to understand these things, you have a past medical history of depression, you have PMDD, you had postpartum depression, your mom had depression, like, we start to understand what are the risk factors. This is where we can then counsel individually. We then also have to say, this is what I say to people, listen, depression is a creep. It creeps on. Most symptoms that you're going to experience as a woman are a slow creep to where you keep adapting, and then you don't even recognize yourself, but you don't even recognize that you're different either. So what I need you to do, and this is especially important for teens who don't want to tell their parents that they're taking the pill, I need you to tell someone close in your life, keep an eye on me. It's not going to be that I'm sad and I'm crying every day. It's going to be, I stopped answering your texts. I'm not interested to do the things that I used to be interested. Like, you say go to the mall, and I'm always like, hell yeah. I no longer am the hell yeah. Something's going on with me. We need to be monitoring that. And then I need you to get back in and see your provider again and get screened. I think every woman should have a mini mental health assessment before she gets prescribed the pill, because it establishes a baseline, and then repeat that 3 to 6 months later, or if you have symptoms coming up, just so that we're screening you and checking up on you and making sure it is working for you.
Yeah, and making the risk-benefit analysis over and over and over again.
And making it individualized. So that's like a mental health piece. I'm sure Marisa has more to say, and then I definitely want to talk about libido, vaginal pain, like all of that, but I want to pass the mic.
Well, before we move on, you know, it's interesting as you're saying that, like, the connection between, let's say, teenage girls on the pill and the prescription of SSRIs. Like, there has to be
It's a pipeline.
Yeah.
We know.
Well, and it's because their brains are still developing when they're on this hormonal birth control pill.
And you know who doesn't see it? Is the primary care provider or the gynecologist who made that prescription, but who does see it is the pharmacist. So if you talk to pharmacists, and I certainly have, they're like, yes, we typically see it is a matter of time of the birth control pill to the SSRI. But when women are struggling with depression, maybe the gynecologist gave them the pill, but they see their PCP, their primary care physician, for the depression, or maybe they go to a mental health worker for the depression, and maybe they don't talk because everybody's busy and things are difficult. But who sees the prescriptions coming through is the pharmacist. And so, you know, we had another episode where I was like singing the praises of the pharmacist. Absolutely, like such an integral and unsung hero of healthcare.
But your pharmacist pharmacists, are they tasked or empowered to
No, that's not a HIPAA violation. They're part of the healthcare team.
So they
it's
might
a HIPAA violation if they go and they tell your insurance, like, hey, I learned these things about her that you don't know because of this professional relationship I have, like, and breaking trust in that way.
But do you think that they're out there like noticing that, oh, I have this customer? I mean, most people are just going to Walgreens or CVS. I mean, I have an amazing pharmacist, but do you think there are many pharmacists in the U.S. who are saying, like, oh, I noticed you've been on the birth control for the last year, and I just noticed you got an SSRI prescription. You know, there is a correlation, potential correlation. Is anybody saying that?
It depends on the pharmacist, but I honestly, for the most part, at least with my patients, no. That is not, well, mainly with my perimenopausal group, where the reason why they're having a lot of symptoms is hormones are erratically declining, right? Without permission, as we've talked about in other episodes. And when we think about hormones decline, we think about bikini medicine, or like, oh, it must be menstrual cycle issues. Let's give you the pill. Let's put you on an IUD. But also you're struggling with all these mental health, because 80% of the symptoms that women in perimenopause are struggling with are going to be brain-related, mood-related, cognitive-related. And so it's usually the pill, and then it's also an SSRI. Like it's a combination.
Yeah. So why is this the first thing that you get? That's what I got prescribed the minute I went in, and I talked about my symptoms. I got on birth control, and they prescribed an SSRI.
The pill is the god that can never be questioned. Yeah. It has been put on a pedestal, and you are anti-birth control, anti-women if you ever question anything about it. I always joke that I need the PR team of the pill, because the pill can do no wrong.
I know.
Like, no wrong, ever. Like, never going to get canceled. Yeah. And, like, listen, we don't want to cancel the pill. No. What I will say to empower women, though, is that consults with your pharmacist are 100% free. You can always ask for a consult with the pharmacist, and they are wicked, wicked smart. And the other thing that pharmacists will say, and I've had them say this with patients, is like, hey, I see you're getting this prescription of SSRI and you're on this form of the pill. We see a lot of women who have more adverse mood symptoms. Maybe you want to talk to your provider about this type of pill. So
what is the difference in the pills? I didn't even know there was a different kind of birth control pill.
Yeah, so we could start with the basic of there's combination, and then there's progestin only. The progestins are really what seem to be implicated in the adverse mood outcomes as we start to talk about perimenopause and menopause. And we were like,
step into that.
Oh, HRT causes breast cancer. You're talking about progestins, which most providers and even researchers, because they just don't understand the female body, are like progesterone, progestins.
They interchange.
Yes, you were just talking about this.
And it's not. It's absolutely not the same thing.
Women are on a progestin-only mini pill, but it is not, one, it's making symptoms worse, or it's not fixing the mood-related or the sleep symptoms. So they're also given an oral micronized progesterone on top of the progestin pill.
Wait, I'm going to make you guys just unravel this a little bit. Explain the difference between progestin and progesterone.
I would love to go off on this.
Go off, Jody. You go.
Here's the thing that you have to understand. Progestin was manufactured in a lab. Shout out to Mexico. They actually discovered progestins, and then they patented it, took all that money, and started funneling it back into making more scientists and researchers. So, wow, love this. Okay. So, not anti-progestin. But progestin, because it's man-made, it can be patented. So, that's the first thing. Like, you could never patent progesterone because my ovary is going to make it.
So, progestin is a synthetic progesterone.
It's a synthetic progesterone, yeah.
So as I talked about in previous episodes, the only way to progesterone is via ovulation or me giving you bioidentical progesterone. So we can also do that. Now, why does progesterone matter so much?
But wait, is bioidentical progesterone progestin?
And it's still made in a lab, but it's identical to the progesterone that we make.
Okay.
And you can look at it structurally, that it is identical, whereas progestin is a different molecule. Now, with the progesterone, if women are like, how do I know? Generic is oral micronized progesterone, and the brand is Prometrium in the United States. That's what you're looking for. Your doctor might say, oh, I prescribed you progesterone, but if you look and you're like, it doesn't say those two things, that's a progestin. And why do we not want a progestin when we're having mood symptoms, we're having sleep struggles? Progesterone is metabolized to allopregnanolone. Allopregnanolone interacts with the GABA receptors in our brain. The GABA receptors are our brake system, our chill out and be calm system. Now, as I say this, there's a caveat. You may have progesterone intolerance. You may have progestin related side effects. And so there's a lot of nuance here. If you have progestin side effects, that doesn't mean you're progesterone intolerant. But if you are neurodivergent or you have a history of PMDD, these are the two cases that I most often see progesterone intolerance happening. And so you will not feel chilled out and calm. You will feel ragey, anxious, and stop sleeping. And you will hate that Dr. Brighton never said progesterone is amazing. It is amazing, but the way we have to use it with you is different because your GABA receptors are interacting differently.
And would that person perhaps tolerate progestin?
Not necessarily. They may or they may not, because progestin does have mood-altering effects in some people's brains. They may or may not. In those cases, when we talk specifically about perimenopause, that's where I start looking at, so here, why do we use progesterone if you look at like traditional OB-GYNs? It's only because you have a uterus. We have to protect your uterus. Forget about your breasts, forget about your mood, forget about your brain, forget about your bones.
With estrogen. So if estrogen was being recommended for osteoporosis or hot flashes or night sweats, we would give you oral micronized progesterone to protect your uterus from basically endometrial hyperplasia. Yes. Yeah.
And so the workaround here is we can use vaginal estrogen and along with vaginal progesterone. If you can take estrogen any way you want to take, but if I have to protect your uterine lining, I do need to give you vaginal or I need to give you oral progesterone. Your Amazon progesterone cream does not protect the uterine lining. We don't have any studies to say that can keep you from getting cancer of the uterus, and that is very, very important. But the big takeaway, I did a whole podcast episode on this. There's lots of nuance of prescribing this. If you have progesterone intolerance, lots of nuance, and I go through all the protocols that I've used with women. But the big takeaway is progestin will never become allopregnanolone, or we like to call it allo. It will never become that. It will never have the positive effects on your brain. And additionally, we know that progesterone is involved with the myelin sheath of your brain. What is that? Would you want to plug an extension cord in the wall without having the plastic on it? Hell no, right? It's dissipating energy everywhere. Your neurons need that same plastic cover so that the thought can run. And so we have to have that myelin sheath protection, and progesterone is involved in that as well. Not to mention, Dr. Marisa talked all about the immune implications in previous episodes.
Okay, I'm gonna reel us in a little and get back to the pill. That was a really good sidebar. Let's stay with the hormonal birth control pill a little bit longer.
I think it's important, that nuance between, because a lot of doctors don't know that they're giving you a progestin versus a progesterone.
No, that was totally news to me, was that there are combo pills and different ways to...
Or even patches. Like a lot will have estradiol, but it'll have a progestin.
But not as a birth control method.
Not a birth control method.
We're talking about HRT.
Yeah.
And I actually do want to circle back at some point in this episode or another and really dial into what we mean when we say bioidentical hormones, because I think a lot of women are still confused about that. But let's really get back. I mean, okay, so the pros of the pill, pretty obvious. I don't think, I'm here to debate both pros and cons. I think the pros are pretty obvious. Ease, accessibility, you can get them in any state, still legal, fantastic. Cons, let's get into some more. We've got mood, and then we're talking, I'm assuming if you have a pill that has progestin, does that lead long-term to potential impacts on your bone health?
Yeah, so not necessarily. We're not seeing the bone implications as much. The biggest question mark is, what do we do with this largest uncontrolled human experiment that none of us signed up for, which is giving the women a pill for decades on end and never actually studying them and understanding if she starts the pill at 14, comes off at 44, now she's in perimenopause, and she's never been exposed to progesterone her entire life. What's happens? I can't tell you. And women ask me all the time, and researchers are like, can we please get funding? And everyone's like, no, because they'll take the pill away from us, or women won't use it. We have to keep, withholding information to get them to sign up.
So women are on the pill for 14 years or 20 years, and a lot of them come off the pill. I mean, it's why you wrote the book Beyond the Pill, and it's hard. There's a lot of symptoms on the back end of it as well, especially if they're coming off the pill into perimenopause, where your hormones have been downgraded and now you come off and they're trying to come back into a rhythmic, cycle, and yet you're in perimenopause too. And so women are struggling with a lot of different types of symptoms.
So what are the symptoms that women should look for besides mood?
So I want to talk about libido, which is a mood symptom.
Yeah, which is
okay.
Libido is a big one.
So I want to just set up the mechanism of action, and then I would love if Dr. Marisa also talks about the perimenopause component, because there's an abuse situation of the pill in that age group. So here's the thing about the pill that we have to understand is that it is a large bolus of hormones that you're taking. Okay, so not like HRT. I would never give a woman in her 40s this amount of hormones that is by design meant to shut down brain ovarian communication. Okay, it's enough hormones that your liver even gets a shot at detoxing it out, and it's still going to shut down the system. Now, in doing that, your body being really wise is like, oh my God, we got way too many hormones going on. We'll elevate a protein called sex hormone binding globulin. So what is the pill doing? It's shutting down your ovaries from doing anything. They're not going to ovulate. They're not going to cycle. We love that. We won't get pregnant. But also, they're about 50% of our testosterone production. And as I explained in a previous episode, and you'll have to go listen to it, the effects of estrogen on our sexual desire. That's gone. Okay, we got synthetic estrogen. We know it's not doing the same. So with that, we lose testosterone. Then we have a protein that rises. Your adrenal glands are going to make up roughly another 50% of your testosterone production. But now, sex hormone binding globulin is gobbling it up. If it's bound to a protein, it cannot be used by the cellular receptors. So we're not getting estrogen stimulation and we're not getting testosterone stimulation. This can also affect our vulva and our vagina, which is why some women see increased yeast infections, UTIs, vulvodynia, that is pain of the vulva. Some estimates say as high as 30% of women may develop vulvodynia being on the pill. It's a big question mark. Did the pill cause this, or was it you started getting yeast infections and now you're having pain? And so it's a complex pain condition. I can't just say the pill did it, it's only just the pill. But there is a strong association there. Then there's the fact that you could also have vaginismus. And I like to think, like, if any of you are sci-fi nerds and you've ever seen the movie Alien, and you're running from the alien, right? And the portal doors are closing and they're just like spiraling in. That's what the vagina's doing, okay? Vagina's like, no, you shall not pass, because the penis is now the alien and this very scary thing. We don't want penetration. And so
because we're already pregnant.
No.
Because
vaginismus is a locking down of the muscles. It can occur for many reasons. Maybe you have endometriosis, you have chronic pelvic pain, you have sexual trauma, maybe you're afraid.
But I mean, so there's no correlation between the fact that the pill is making your body think it's pregnant all the time.
That's a lie. That's a lie.
That's a myth.
No.
What? Do you think your body's that dumb?
Myths left and right, ladies.
Okay, hold on. We've got 3 types of estrogen. Estrone, primary estrogen that is happening in menopause. Estradiol, when you're cycling primary estrogen. And estriol E3 is what you're manufacturing during pregnancy. Estriol is not what is in the birth control pill at all. Your progesterone is jacked up and naturally high. They lied to us about this. There's a lot of getting us to buy into the pill, and one of the lies is it just psychs your body out to think it's pregnant. And since women historically spent most of their life pregnant, this is probably healthier for you to try to artificially induce your body into a pregnancy state, because that's ancestrally what they would have been doing.
That's a bad selling point. Okay, wait, let me ask. This is a kind of a sidebar, but I just got to ask on this note. Is there truth to the hypothesis that women on the pill are attracted to like snuggly, cozy men? Is this true?
It depends on the woman.
I'm going to say this.
I love this story.
Men's hormones affect their behavior in their brain, and women's hormones also do that.
Shocker, right?
Understand that, because whenever we talk about this, it is immediately that I want to call them pseudo-feminists, because I think if you're truly a feminist, you are about informed consent, you're about curiosity, you're about getting all the information into women's hands, and not about shut this down, you can't talk about it, because if you tell women about this, then they might not use the pill, or
the pill might be taken away. It might be weaponized.
It might be weaponized. So here's the thing that we understand from the research. There have been numerous studies that are done. Women on the pill may gravitate towards a face that's more feminine when they're looking at men, when they put men's faces up. It also changes how we smell and perceive men. I hate to break it to you all, but we're animals. We are absolutely animals. What? And just because we have a language that we can understand and we think we made technology, we've done all these things. Great, ants build crazy things too. Like, come on, like we're all animals. So It can change scent of both men and women, how they perceive each other. There's been studies of strippers make more money when they're ovulating. Why? We're plump. We've got plump lips. We've got plump hips. We've got plump breasts. Thank you, estrogen peaking. But we're also putting off pheromones as well.
Yeah.
If you're on the pill,
ovulation.
the attraction can change. And so it's very interesting because I wrote about this in Beyond the Pill. I had a patient that depending on whether she was on or off the pill, she was into this guy and not into this guy. I've had women who were attracted to partners. They got in relationships with them. They come off the pill. They're like, why was I ever into this? Now, is this true for everyone? It's not true for everyone, okay? But we have to be curious about this. If hormones alter who we are and shape our behavior, then the big question mark is what happens when we start playing with women's hormones? Because we know how men's behavior changes when their testosterone gets low, and then we come in, we give testosterone therapy because heaven forbid they can't feel bad for 1 minute, right? And I love that they get access to that. I just would like a little fairness here, a little equity.
Yeah, no, it's interesting that you're saying that, because when I think about the first thing that I got prescribed, as I've talked about when I was in perimenopause, was birth control. And I was so, it could have been a plethora of things I was going through, but I was so unattracted to my partner. I was so repelled by his presence when I was taking the pill. Everything about his smell, his whole experience, I'm like, do I need to get a divorce? Is this the wrong person? And I'm just curious, the long-term effects of that. I got off of it because I got put on HRT once I found the right doctor.
Wait. So you got to have Marisa, we got to talk about that.
Yes.
Because you got taken off the pill and given HRT. Love that. Whoever your doctor is, shout out to you.
Dr. Shepard.
Yes,
Yay.
You're amazing.
Well, and shout out to you for advocating, because if you hadn't said anything, they just would have kept you on that until you were 53 or 55 years old.
But I did what Dr. Brighton's saying. I kept the baseline because I was really in tune with what was going on. And I went through 4 different doctors, all of who were not listening to me, were ignoring all of my symptoms, told me I needed my body to do its thing. One doctor actually looked at my file.
You're not doing the thing, though.
One of my doctors, I've talked about this before, but basically said to me, your body is broken, is what he said. And I'm like,
that
okay.
Straight to jail.
Yeah,
Straight to jail.
That feels like the narrative that we've talked about a lot in this show, in this season, about women feel like being blamed that they're broken, that it's their fault. And then also
because
we have
things are common,
yes, things
does
are
not
common,
mean
that
they are normal.
And we have to acknowledge the gap here, the knowledge gap in the healthcare system when it comes to women, particularly who are experiencing premature menopause or early menopause, but even just perimenopause. The reason why the gold standard of care for women in perimenopause is going to be hormonal birth control is that's where the education stops. This is what we recommend. This is what we do for women when we have these symptoms, especially with HRT being off the market because it's dangerous and it's causing all these issues in women, chronic diseases, which not true. And so what do we have? We have hormonal birth control when you come to me with symptoms due to hormones that are erratically declining. That's what we're giving women.
So when you get people, let's take the early menopause aside, and when you get women in your practice who are pretty clear to both of you that they're on the birth control pill and the symptoms that they're experiencing are related to the hormones from the pill, give us your protocols. What does it look like?
Personally, do you want to have a baby or not?
Let's go down both paths. Yes, I do want to eventually have a baby, but I don't want it now. So I'm on the pill because...
I have to say that if you want to have a baby, that's a whole podcast in itself, right? Of a fertility protocol, what we're checking your partner, all of that.
So for just sticking with the pill, if someone comes and they're like, you're like, okay, so what are you taking? And they're like, this, and here are my symptoms, and I'm on the pill. And you're like, oh, okay, lady. So let's look at this symptom and acknowledge that these are very common symptoms from the birth control pill. Did you know that? They probably don't. Mm-hmm. And then you fill them in, and then do you wean them off? Do they stop the next cycle? For people at home who don't have an amazing doctor to talk to, what we really are trying to provide is How do you know what a path forward might look like, and then go to your gynecologist and say, hey, I want to try this. This is something I'm interested in, or your PCP, and this is a path I'd like to go on. So what might that path look like for them?
Firstly, I don't tell patients what to do, and I don't make decisions for them. So I'm not going to say you need to come off the pill.
Yeah, no, I recognize.
It's informed consent at the end of the day.
I want women to hear that from a doctor.
Right.
That this is not how it should go. This is a partnership, and my role in the partnership is not deciding factor. Unless the prescription is not safe for you, I have to make that decision. My role is to educate you and help you find what is going to be best for you. So the very first thing is, if you don't want to get pregnant, we've got to figure out how not to get pregnant. If you are in a heterosexual relationship, okay, that's the caveat. Because you could be in a same-sex partnership, but you're on the pill because you have endometriosis. Not a treatment for endometriosis, by the way, but it may be working for you to just never bleed. That may be working for you. So I think, there's so much nuance to this conversation. If you are, to your point, do you need to wean off the pill? No. You can just stop it. You just stop it. That's it. There's no weaning. Don't do half a pill or anything you're messing with your body.
But there's support to bring in.
Right.
While you're getting your body back online, right? Supplemental support, gut support, a lot of lifestyle medicine that can help and support.
Lay it out there.
Well, okay. So first thing I want to start with, because we've been talking in the perimenopause arena, is metabolic mayhem. We've got to figure out, what did the pill do with your insulin, your CRP, because for some women it's raising those things. There was a study that showed that if you go into menopause and you are on an oral contraceptive pill within 5 years of making that transition, you are at even higher risk of insulin resistance. So we need more studies to understand that a lot better, but that is a consideration. So we got to look at the metabolic health. We have to understand what is going on with your microbiome. So a lot of people do not understand that the birth control pill, among many medications that exist, can alter your microbiome. So we think you just absorb it all, right? Now it's making its way to your large intestine. So we're checking on what's going on with your microbiome. And one thing you can do right now is go back to our last episode and hear all the fiber talk that we did. That's going to be really helpful for you. Nutrient depletions. The pill is one of the biggest culprits of things like vitamin E, vitamin C, multiple B vitamins, magnesium, zinc, selenium. We're talking about thyroid function. We're talking about your ability to sleep. We're talking about anxiety, headaches, all kinds of things. So we have to replenish those nutrients as well. We have to look at what's going on with your stress. We have to start to understand the HPA axis and hypothalamic pituitary adrenal axis, for everyone to stay with us here. So what's happening with your stress response system? How does it relate to your thyroid? And make sure that we're addressing that as well. And then, by the way, this is not the last thing that you do. These are all the things that we're doing at once or considering at once, and then trying to formulate a plan specific for you. And in Beyond the Pill, I actually lay it all out so you can do this on your own and work with the provider, but is understanding your hormonal issues that got you on the pill or that are persisting right now. So maybe your testosterone didn't come back online because your sex hormone binding globulin is still up. You're losing muscle mass. You're not motivated. You don't wake up and kick ass. You're a pushover. You don't set boundaries and people are walking all over you and you're a people pleaser. This is what testosterone looks like. This low testosterone archetype is a frail archetype in some ways, where it will activate more the HPA axis, which I'm sure either of you could talk about.
Well, and the stress response system completely hijacks that as well. But to Jolene's point, it's why did you get on the pill to begin with? And, how do we begin to bring back that equilibrium and homeostasis in your body? And then, for you, exactly like what happened with you, Rosie, and so many other women, how do we then move you over to hormone replacement therapy, including testosterone therapy, if that's what's needed?
Yeah. But also, I will say with side effects is that you don't always have to just stop the pill. So we know something with birth control and SSRI side effects, something like saffron, specifically Afron is the one that has clinical trials, can help with the mood symptoms. So maybe you're I can't just get off this pill. And also I just bought 6 months and my insurance doesn't cover it. There's financial decisions. We can look at something well, why don't we bring on saffron? We know this can help. We know it won't interact with medications. So we can also look at natural ways to support you so that it's not always this
either or.
Yeah. And I think, Marisa, in a lot of things that she said yes and in so many of these episodes.
There are a lot of young women on the birth control pill. So without going too far into it, if someone came to you and they were like, yeah, I'm on the pill, I don't love how I feel, but it's my skin, my gosh, I couldn't get off it because I love how my skin looks. Like, what other hormonally related protocols would you give them to address that particular?
A lot of what we talked about already today, I would be looking at the gut microbiome. I would be looking at metabolic health, so blood sugar regulation. I would be looking at nutrient deficiencies. And then I would also be running a full hormone panel just to see what's going on, if it is testosterone or sex hormone binding globulin is involved, and taking a look again at the whole picture of a little girl. You know, we know that a lot of girls, particularly in puberty, are struggling with issues of insulin resistance and metabolic issues that are then driving. You know, when I think about one of the most metabolically driven processes of the body, it's our reproductive health. They're so in connection and in consort with one another. And so if we've got poor blood sugar regulation, we're going to see issues in the menstrual cycle. We're going to see irregular menstrual cycle. We're going to see polycystic ovarian syndrome. And then we may even see like acne issues. And so I would be looking at all of these pieces and really investigating what is the root cause that's driving the acne.
The top reason a PCOS patient is going to get on the pill is going to be acne or irregular periods, and that's going to delay their diagnosis. And as it is, you're seeing 2 to 3 specialists before you even get believed about your symptoms, and you still might not get that diagnosis. What is fascinating about the research is that if you look at PCOS, it can take you years to get somebody to believe you. Same with endometriosis.
Same with thyroid issues.
But the second you say, I want to have a baby, it cuts the diagnosis time down by 3 to 4 years. 3 to 4 years by the magic phrase of, I want to have a baby. But if it's just skin issues, put them on the pill. And listen, why is your doctor doing this? Because they want to help you.
Is the root cause of the acne and the PCOS the same thing?
Oh, so let me say this. Okay, so the metabolic issues that Marisa was talking about, what we see in PCOS, we don't actually know the root cause because we didn't bother to study it. We do know 70% of those with PCOS have elevated insulin. The ovaries of a PCOS patient are very unique. Insulin hits them, they produce testosterone. Testosterone drives sebum production, which is the oil of your skin. That is the mechanism that starts the cascade towards acne.
Yes. So again, 70 to 80% of women who are struggling with polycystic ovarian syndrome, we do see a metabolic component. But there can be other reasons that is driving a polycystic ovarian syndrome as well. But often it is metabolically driven.
Got it. There's another episode, ladies. Putting a pin in that. All right. Woo!
The one thing that I do want to offer in this arsenal that these brilliant doctors are giving us too is the importance of mental health in addition to everything that we're talking about, you know, going down those checklists that Dr. Brighton talked about and really paying attention to where your baseline is, having the proper informed consent, and also supporting yourself, like giving yourself an opportunity to feel supported, to talk to somebody about it. Just like Dr. Brighton said, that was brilliant. She's like, have somebody that you can talk to that knows you.
Yeah.
You know, so I think that's an important thing.
Or that's
to know.
open to listening, open to hearing you.
Right, a professional that's willing. All right, we're gonna bring in a few questions from our listeners. The first question here from Lauren feels really close to my heart. I want to have a really frank conversation with my daughter about birth control, and give me some hot tips. Who wants to take it?
I love this question. And I think it's important that we're having these conversations with our daughters about birth control, about their reproductive health, so that they really understand what is going on. I think that first step is us feeling like we're informed about what is happening with our body throughout our normal menstrual cycle, but then also what happens when we bring on very different types of birth control, whether that is a combination pill or it's a mini pill or it's an IUD, and explaining to our daughters the options. So, you know, getting a book or listening to a podcast that really goes into the breadth of the differences so that they know what they're getting into as well. Breaking down maybe potential side effects, but also potential benefits, and figuring out what feels best for them so that they really have that informed consent between you and her, and then finding the right doctor to continue that conversation.
Yeah, and setting up this really important piece. This might be the first time you really set up with your daughter, and hopefully your son too, because they should also be having a contraceptive conversation.
Absolutely.
But that this is all informed consent, that every part of your healthcare, it's not just about your reproductive health, that all parts of our healthcare are about advocating for your informed consent and looking at, because so much of our health is a risk-benefit analysis.
Absolutely. And it's one thing to have contraception, but then, also we want to mitigate against STDs. The IUD isn't going to do that, or
Right.
the combination pill isn't going to do that. So we need to open the conversation to how are we mitigating that as well.
I'm so glad you added that.
Good old STDs. 11 STD. All right. You can take this one, Jolene. An anonymous listener asked, what are the risks for breast cancer and the birth control pill?
So when we look at the birth control pill, we do know that there is a mild increased risk for breast cancer. However, with that in mind, there's also many modifiable factors of your life. Do you smoke? Do you exercise? What are you eating? Do you have a family history is also part of this conversation, but I want people to know there's the genetic component, but then there's the environmental component. So when we're having this conversation, just because there's a mild increased risk doesn't mean you're going to get breast cancer for sure, especially in light of we can educate you around everything else that you can be doing to lower that risk. Now, with that said, we also know that there is a diminished risk of ovarian cancer and endometrial cancer. Now, I don't want you to get any cancer, okay? Really
With
clear.
the birth control pill, there's a reduction in those risks?
Yes. Yeah.
Similar to HRT.
So you're keeping the uterine lining thin, okay, so you're not getting that stimulation of it. And the ovaries are also just not working while you're on it. I think what is really important for women to understand, so I don't want you to get any type of cancer, okay? None, if we can prevent it. We're really good at catching breast cancer. We do that well comparatively to ovarian cancer. So it becomes a different conversation if your mother had ovarian cancer. Then we start talking about, well, there is a mild increased risk with breast cancer. However, there's a reduction for ovarian cancer. But this is not enough. I need that to be clear as well. Like I just said, we know some of the most impactful things in preventing cancer is what do you eat, how often, and what kind of movement do you do, and how well do you sleep? And those things are within your control. So whenever we have the cancer conversation, the media loves to be like, you're all gonna get breast cancer, no one should take the pill. Not true. There's so much more nuance, and I don't think we should approach this from a fear-based perspective, because for you personally, the pills may still have utility.
Cost-benefit analysis. It's really interesting in this health survey that we did, that one of the main responses that came up was not questions about the pill. What was, I want to make sure the option of the pill is not taken away.
We all want that.
Right. And so,
100%.
And I think that it is so interesting that there is this initial response that like any criticism of the pill is going to lead to an attack on our rights. We are in a fucked environment right now for women's rights and women's access to all kinds of medical health.
Can I say something that might shock you?
And this is a part of it, but I would say that part of it's urgent that we are able to have honest and frank and like holistic conversations about these things while acknowledging that the most important thing is that women have the right to determine their own choices and their own health. But yes.
You who are listening right now would be shocked at how many conservative women want access to the pill. And as someone who spends time reaching across the aisle and actually going into red state environments to teach medically accurate sex education, I've spent time with a lot of women who consider themselves conservative Christian, and they want access to reproductive technology as we have it across the board. And so, well, you say that, like, we're in this bad political environment and stuff, and we often see as this us versus them. One of the most powerful things we can actually do right now is reach across the aisle to someone that you might have already made your mind up that like they're anti-birth control, and realize that women collectively want access to this, and we absolutely can retain access to this if we unite.
The best thing we can do to work against a really bad political and medical environment is to find allies even in unusual places.
Yes.
And to find where we have commonalities, strong commonalities, even if we don't agree about everything. On that note, any questions lingering that you women have that we might want to fold into a future episode?
I would say that the biggest question for me is, and still continues to be, why do we not have more access to education and make informed consent accessible to everyone, specifically for minority women who are by far more impacted by all of these issues?
Good one, tough one.
We touched upon it earlier, Jolene did, in terms of looking at the research, like long-term research of women on hormonal birth control. And in the experiment that we are in today, I would love to dive deeper into that, but also question why we don't have that research.
Because we've got a lot of guinea pigs in the mix.
Yeah, there's a lot of, we have a lot of data that we could be collecting.
Yeah.
The only reason the American College of Obstetricians and Gynecologists ever changed their recommendations for IUD placement and pain management was because of the outcry of women on social media. So I want you to understand that even if you tell your story and you feel like no one's listening, you are shaping and changing women's health for the better.
Always. Yeah, speak up, ladies. And then this isn't really related to the pill, but the end of our conversation brought this up, and it was a question that also has come up a lot from listeners, and that is, I would love to know, and women would love to know, the risks of mammography and versus
Thermography.
Thermography. Thank you. Thermography
thermography
versus mammography, and this is in the theme of cost-benefit analyses. I'd love to look at that. All right, more topics, just more questions. Thanks, guys. Talk to you really soon. Thank you so much for joining this episode of the Luminescence podcast. Our show is powered by Commune, which is an all-in-one course platform for living a happy, healthy, and for Luminescence fans, horny life. Many of the almost 200 courses on Commune address women's holistic wellness specifically, including more wisdom from Dr. Jolene Brighton, yoga and breathwork classes from yours truly, and dozens of other classes with leading female health experts and teachers. So just go to onecommune.com to learn more. That is ONE commune.com. Also, wherever you're watching or listening to the show, be sure to subscribe and please, please, please leave a comment. You will be helping us to shape the future of this show. All right, that's all for now. I'll see you next week.